Welcome. First, I want to say thank you so much for joining us for our first 50 plus health, strong and healthy webinar of 2021. My name is Anthony Anderson, and I am the program coordinator for the treatment department at NMAC. As a department that works closely with the 50 plus community living with HIV, we knew when planning our webinars that we had to discuss the impact COVID-19 had on this specific community. It is known that older adults and people of any age who have serious underlying medical conditions might be at higher risk for severe illness, including people who are immunocompromised. With this in mind, we wanted to create a webinar that focused on how HIV clinics and social services are addressing COVID-19 and the needs of HIV 50 plus clients. Not only this, we wanted to know how are they ensuring that they achieve the most positive treatment outcomes. Today, we are very excited to welcome Dr. David Fessler, who is the Director of Clinical Practice at Women Walker, a local DC clinic. Dr. Fessler is an infectious disease physician specializing in HIV care. He completed his medical school at Washington University in St. Louis in 2005, with a residency in internal medicine at Beth Israel Deaconess Medical Center in 2008. And was a fellow in the infectious disease program at Bethel Israel Deaconess Medical Center in 2011. Prior to working at Women in Walker in 2016, he was on faculty at Beth Israel for 5 years as an infectious disease and primary care physician. Along with Dr. Fessler, we also have Dr. Judy Tan, who is an assistant professor of medicine in the Division of Prevention Sciences of the Center for AIDS Prevention Studies at the University of California, San Francisco. She is a behavior and prevention scientist trained in social and health psychological theory, quantitative research methods, and intervention development. Her research combines theory building and qualitative methods to explain multi-level causal processes of health and to develop novel interventions to reduce health disparities, particularly those among sexual and gender minorities, people of color. Thank you to both of our panelists for joining us today. We are so excited to have you both. We will start with Dr. Fessler and move on to Dr. Tan and take questions at the end. Thank you so much for joining us.
Great, thanks so much, Anthony. I'm just gonna share my screen here. Let me see here. Okay, can people see that?
Yes, we can see it.
Okay, perfect. Okay, great. So yeah, so thanks very much. I'm just gonna hide the control panel so I can actually see my own slides. There we go. Yeah, thanks very much. I really appreciate being asked to speak today. You know, this is a little bit of a kind of a smorgasbord because you know it's kind of talking about health in people over 50 living with HIV in the age of COVID. So I want to sort of talk about a little bit where our clinic has come from in terms of the kind of challenges and moves that we made over the last 10, 11 months, and both in terms of kind of dealing with the new kind of reality on the ground, but also how to kind of optimize health and optimize kind of preventive care in patients who need it, and in light of these difficulties that COVID has brought on. And then I'll kind of end with some kind of just general guidance for patients, for people living with HIV, and how to kind of ways to sort of think about optimizing health given the kind of limitations, these new realities that we're facing. So for those that don't know, so like Anthony said, I'm an infectious disease doctor at Women Walker Health, which is a federally qualified health center in Washington, D.C. We're an LGBTQ focused community health center that's been around since the 70s. We serve about, in the neighborhood, I think it's up to about 15,000 medical clients a year, including about 30% of those are people living with HIV. So about 3,500 HIV positive patients. And in addition to that, we do a lot of sexual health testing and treatment, a ton of PrEP. I think we supply over half of the PrEP in the city of Washington. We also have other services, including behavioral health and addiction support, legal aid, dentistry, and a whole slew of other things too. So we kind of really try to come to it, kind of try to be kind of one-stop shopping for our community. We serve a diverse clientele in terms of racial and ethnicity backgrounds. Our patients are about 2/3 identify as male, and about 15% identify as transgender as well. So sort of like thinking back, it seems like yesterday and a million years ago that all this started happening, but just as kind of a brief, history reminder of what's been happening over the last year and kind of how it tied into our practices and redesigns as well. It was just about a year ago, January 21st, that the U.S. had their first case of COVID. And this, I think that little clip from CNN.com on the left was, I think, from late December, early January as well, talking about how this new illness in Wuhan, China is linked to SARS. I kept a couple of additional random stories at the end, because I thought it was, given everything that happened with cruise ships in the month or two afterwards, I thought it was at least ironic that on the same day as this, the Carnival Cruise Lines had banned offensive clothing, as if that was a main news story. So it's about a little more than a month after the first case was confirmed in Washington State, that we had the first death in Washington State. This particular timeline is kind of Washington State focused. Where a lot of that first early outbreak started happening. And once you started getting into, beginning of March and then throughout the end of March is when kind of all hell started breaking loose. You had stay-at-home orders, you had Washington State kind of closing down essential businesses, schools closing. And you can see, as in late March, it was you started getting concentrated cases of sort of pockets of COVID around urban areas around the U.S. And likewise, as it went from late March into early April, all the states started issuing mandatory stay-at-home orders. In Washington, D.C. was on April 1st. This was obviously new realities for everyone in terms of health centers. It added additional challenges. So this is a kind of screen cap from our website from the end of March, talking about how our first responsibility is to keep everyone safe and healthy, and we're starting telemedicine visits and not accepting walk-ins. It's from the same day that basically what we did in that sort of second half of March is we essentially, as the kind of reality hit, we kind of closed down our clinic for a couple of days and did a complete practice redesign. Prior to COVID, we essentially had no telemedicine. We had everyone was coming in for in-person visits and walk-in visits and prep clinic and, our STD diagnosis and treatment center and all the different services that we provide. And we basically, in a span of a couple of days, just kind of shut everything down. And for, that first really what turned out to be about 3 months, the only in-person care we provided was an in-person respiratory clinic for kind of COVID testing and kind of triaging people with respiratory symptoms that were suspect or demonstrated to have COVID. And everything else we pivoted to telemedicine. It was a huge change for everyone. So along with that kind of redesign in our own clinic, there are all these new things that we had to start thinking about. Probably buying 30 times more PPE than we had prior to this, N95 masks and gowns and gloves and face shields and all of that. This new respiratory clinic was a totally new model, and how to do that safely, how to just even in terms of bringing in people to how do we deal with elevators and people just showing up at the front door and go to appointments and all of that, starting a new telemedicine program from scratch, ramping up our own infection control. What do we do if a patient or staff member is positive for COVID, and how do we do contact tracing? Really moving to really a work from home model for most of our staff. And all the while in these kind of early months, we're dealing with really rapidly changing information and guidance from the CDC in terms of how this was transmitted and what people should be doing in terms of quarantines and staying at home and testing. And all this is shifting very quickly. This is a huge challenge from a healthcare front, in addition to just kind of the everyday realities that everyone was dealing with. But as it got sort of, everyone started kind of gradually realizing that this was not going to be a short process, that we were kind of in this for the long haul. As we got further into the spring, we started really thinking about, okay, this was kind of a crisis mode and a change we had to make right off the bat, but how do we kind of step back and continue our mission of giving top quality, primary and preventive care and all the other care we are providing to our LGBT community and people living with HIV. One of those is sort of thinking about how to leverage telemedicine. We sort of brought that in early on, and as we were sort of doing it really exclusively throughout the spring, we started, realizing a few things about it. We started surveying patients and surveying providers of what the experience was like, and starting in July 1st, we actually started doing some in-person primary care again, and it's kind of grown since that time. It's currently, even now, 7 months after that, there's still a mix. We're sort of limited by our, space constraints and the ability to do distancing in the space that we have. So we're still definitely below our capacity for in-person visits. But we're, back up to, a reasonable number. And providers are continuing to do a fair bit of telemedicine to kind of make up the difference. And what we found after kind of talking to patients and talking to providers is that generally telemedicine was pretty popular with the majority of patients. I think that was, characteristically people who were tech savvy, people who were already used to things like Zoom and other modalities of kind of video calls and things like that. And it was popular with kind of the generally kind of more savvy and educated population. There were some people that really preferred and missed the in-person visits, and as soon as we started doing in-person, came back to the fold. And then there were people who absolutely fell through the cracks, and there were people, there were kind of recognized, frustrations, and early on, and particularly when we had more elderly people that were not quite as tech savvy, and were doing these telemedicine calls really just by phone. Maybe there's spotty connections, there's complex medical needs, and it was just really, really difficult. Those were folks that were really tried as soon as we kind of opened up in person to get back in. So that's kind of the history, and then sort of especially early on, and kind of where we are now. And what we tried to do over recent months in terms of kind of creating a new normal is on a couple of fronts. One is COVID specific. So, a good number of our patients at some point over this last 11 months have had to quarantine, either because of a close contact to COVID or symptoms that they themselves are having, or a confirmed case of COVID. And, we wanted to kind of add additional layers of support for those situations when people are kind of, we really don't want them leaving the home, and how can we continue to provide care? And that's, that's one instance where telemedicine really has proven to be very useful. So with patients that have been diagnosed with COVID, we're at home, we're doing kind of telemedicine check-ins every 2 to 3 days, just because we know that things change and people can be doing well one day and less well the next. So we wanted to really be able to stay on top of that. Ability to reach, we really tried to expand our patient portal. It had a decent amount of use pre-COVID, but after the age of COVID, people started using it a lot more, and we wanted to make sure that we're kind of educating people on how to utilize that and to reach their provider via messages through the portal, and requesting refills, and really kind of expanding the communication. Our pharmacy that we have in our building, prior to COVID, did a little bit of delivery, but not much. And they really, as we turned on a dime in our medical clinic, the pharmacy turned on a dime as well. And they essentially switched to 100% delivery model, where they were kind of doing home deliveries to patients. And again, in patients that need to kind of be at home and not leave, you do not want someone with COVID walking into a pharmacy. So the ability to kind of do delivery to the home of medications is really important for our patients as well. Working with the DC Department of Health to support kind of needs for groceries, things like hand sanitizer and gloves and PPE, which there's some funding and organization for in the city. And then paperwork, work letters, FMLA forms, all that sort of stuff that are kind of realities of what COVID is doing to other aspects of our patients' lives. And we all had to adjust. It was easy in some respect that when we were seeing people in person and they had a form, they give us the form, we fill it out. But when everyone's doing this remotely, we had to figure out the technology to be able to kind of fill out forms, digitally and all that sort of thing. So that's kind of another learning curve for us. But in terms of kind of pivoting to what we've been trying to do to kind of prioritize and get back to our mission and work on primary and preventative care for particularly our patients living with HIV over the age of 50, there are a few things that we've been working towards. One is giving flexibility. People have different needs and different ways that they want to interact with the healthcare system. And for those that are doing great on their telemedicine, we're continuing to offer telemedicine. For those that have more complexity or really need that in-person touch, we're offering our in-person visits at both of our sites. Likewise with labs, we have our lab draws in our building like we always have, and we kind of expanded to LabCorp sites. So we're individuals that are coming from 30 miles away in the suburbs who happen to have a LabCorp down the street from them. That's a really good option. And then another aspect is that, like I said before, people absolutely fell through the cracks, and there were folks that as we started looking into it, as it got into the summer and fall, realized, have not seen their provider, haven't gotten labs drawn, haven't requested refills on their HIV medications, haven't gotten their flu shots, et cetera, in months and months. And we were able to kind of proactively outreach to those folks and try to get them in to see their provider and re-engage. Some of the things that went along with in-person visits, it's, while there are certain inconveniences of having to come in and deal with parking and all those sorts of things for in-person visit, you are right there and you can get your vaccines and get your labs drawn and all of that on site. Whereas with telemedicine, that's kind of separate issues. So we're able to kind of buff up our processes for getting people in for kind of vaccines that need them, STD treatment for people that need it, and try to buff up our systems for allowing for that as a kind of a separate process than kind of in-person clinic visits. We brought up a standalone flu shot clinic for similar reasons. I mentioned the pharmacy, mentioned the patient portal, and then we're trying to maintain our communication with patients as well, particularly related to kind of the COVID vaccine. We in DC, obviously, we have people coming in to see us from Virginia, Maryland, and DC, as well as occasionally other states, West Virginia, et cetera. And all these states are different. In Maryland, all the counties are different. In Virginia, all the counties are different in terms of what phase and tier places are in. So we're trying to kind of maintain a central clearinghouse for patients on our website for who's eligible, and also kind of started a COVID vaccine hotline for our own patients, where we can, for those who are having difficulty kind of navigating the web-based system for signing up for vaccines in this kind of mad rush where a batch of vaccines gets released, a batch of appointments gets released at 9 a.m. and by 9:15 they've all been taken for the day. We can try to be advocating for our patients and work with them and kind of be with them on the phone and trying to kind of be on our own computers and getting them signed up ourselves. We also have a self-testing clinic for COVID where people same day can come in and swab their own nose and don't need a medical appointment, can just kind of like pop in, pop out, get their COVID test done. And then the kind of biggest piece is really encouraging re-engagement in preventative services. I think a lot of folks, a lot of my own patients, with everything going on, and the fear surrounding COVID, start to punt on things. They're uncomfortable coming in for visits. They're uncomfortable going into LabCorp to get labs drawn. They're uncomfortable doing things like colonoscopies, and they just kind of, over and over and over again, here like, I just want to wait. I just want to wait. And, months go on, and suddenly months becomes coming up on a year now, and other health conditions don't necessarily, wait just because COVID happens to be around. So we're really trying to kind of re-engage and work with people to get them back into their preventive care as well. And that's what sort of centered along that. I wanted to kind of just give a couple of thoughts on, the things that I kind of focus on with my own patients as well, of trying to kind of optimize, health in the age of COVID, which is one, try to stay engaged. It's particularly, for when people are struggling at home, there's isolation, there's not wanting to go out, and fear of contracting COVID, and things slip away. So I think be staying engaged with your provider team, with friends and family, and then staying engaged with the world. Finding ways and whether it's virtually or outdoors with a mask or what have you, kind of finding ways to kind of stay social, stay engaged with the world. Staying active, I would say, 2/3 of my patients have put on at least 10 pounds, since over the last year. Everyone's working from home or furloughed or unemployed. The kitchen's right there. So many people talking about the COVID-20. So just kind of a reminder to kind of focus on your health, and even with everything going on, try to get out of the house, find ways to exercise, get out of the kitchen. And really try to use this as an opportunity. Sometimes I have patients who are doing healthy cooking classes, or finding kind of new ways of trying to stay healthy. And then staying on top of your health, including preventive care. So things like, it's very easy with everything going on to kind of kick the can down the road in regards to things like, routine vaccines and colonoscopies and prostate cancer screenings and things like that. So making sure that patients have a plan for their care. How are they going to get their refills of their medications? How are they communicating with their provider? Following up with their PCPs and their specialists and labs and prescriptions, and then staying safe and getting vaccinated when you can. I'm happy to, obviously the COVID vaccine is on the forefront of everyone's mind right now. It's where all the news stories are. This particular session wasn't focused on that, but I'm happy to talk about it in as much depth as anyone wants to in the Q&A portion. But the short, what I'm trying to message to my patients is, even though this was, an unprecedented in terms of the speed where a vaccine got developed and brought to market and approved, the data looks far better than I was expecting, and most people were expecting, both in terms of the safety profile and the effectiveness. So I'm trying to kind of work with patients who have concerns and hesitancies about vaccines, and trying to get to a common place where there's a comfort level. I'll stop there and kind of leave everything else to kind of any kind of questions that you guys have, and happy to turn it over. Thank you.
Thank you, Dr. Fessler. Now we'll move on to Dr. Tan.
Hi, everyone. Are you able to see my my screen?
Yes, we're able to see your screen.
Great. And just a reminder to presenters, because I will be showing a video later, to mute yourselves so that there's no feedback. Thank you all so very much. Special thanks to the organizers of this wonderful panel, to Anthony and Chip. And it's a pleasure to be here today to talk about some research studies that I am doing here in the Bay Area and elsewhere, adapting my research to a pandemic reality. There's a first time for everything, and boy, is that the truth during the pandemic, COVID-19. We exist in unprecedented times, as we all know so well and so intimately. It seems to be the common thread throughout the entire time. We've been unable to hug our family, our friends, our neighbors. Everything that we knew has been upended and uprooted and turned upside down. And so I obviously don't need to emphasize that any more than it already has been, but for research, for conducting research in the community, it has been particularly interesting and particularly difficult in many respects. And I'm here to talk about some of those adaptations that we did. And specifically, I want to talk about two of my studies that we have implemented during COVID-19, during the pandemic. And these two studies actually were funded and began around the same time that the pandemic really took hold here in the United States. So first, I want to talk about a study that in which we had to adapt our recruitment strategies. And this study is a R01 funded from NIMH, the National Institutes of Mental Health, and it is a study with Black gay couples. here in the United States. And then the next study, the second study I would talk about, where we adapted our research question, is a R21 funded by the National Institute of Aging, or on Aging, and it is a special project close and near to my heart. It is a group singing intervention for older adults living with HIV. In talking about this, the first project, which is a large R01 funded study, it is to develop an app to promote HIV care engagement in Black gay couples. It's called LetSync. It is to target, promote care and treatment engagement among Black, gay, bisexual, and other men who have sex with men who are in couples. Well, why are we focusing on couples? Well, there's a bunch of research that looks at individual behavior, and with the implicit assumption that differences in behavior, individual behavior, are responsible for the disparities that we see. But we all know, with especially, it has come to the forefront for many of us this year especially, that there are systemic things that occur in society. There are systematic inequalities or inequities in society, and that inequality exists at multiple levels. And one of those things, and we need to look beyond individual level dynamics in order to understand individual behavior in the context of people's situations, of people's environments. And one of those levels of impacts are the dyadic level, and that is a new area of research for me when I started looking at behavior. So one of the levels that I became interested in intervening is at the dyadic level. And I argue that the dyad is actually a missing level, often missing level of intervention in multi-level approaches to health, because many of our daily activities actually take place in the context of another person. And whether you are in a relationship with another person to whom you feel the most committed, whether you have a parent, whether you have a child, whether you have a friend, there's someone in your life that I bet you, in thinking about, the last time you maybe had a conversation, or had a healthcare decision, or had a meal, or you went grocery shopping, all these things occur in consideration with another person. And so my argument is that health behavior as wholly individually determined may be an incomplete approach to understanding health behavior. And so the focus of this R01 study is to first investigate couples dynamics, especially as they relate to couples resilience, in order to highlight it and to harness it in care engagement among Black gay couples. Then the second aspect of this research is to develop an app, because everyone has access to technology these days, especially to a mobile phone. Obviously, there are exceptions to the rule, but for the most part, in fact, there are lots of evidence actually that shows that that mobile technology is often the primary and often the only way that many people who are lower socioeconomically speaking have access to healthcare and to health information, for example. So looking at technology, mobile technology, and leveraging an app to implement a intervention called LetSync, which stands for Let's Synchronize. And then the third aim, or the third aspect of this research, is to pilot test this intervention with 80 couples. One of the approaches that we employed to engage couples is one of the investigations that we wanted to do was we wanted to interview couples to understand dynamics within the couple in order to understand what to leverage, what to target. And so what we had proposed in our aim 1 of the R1 research was to interview 24 couples, which is 48 people, individuals. And we're focusing on primary relationships with the acknowledgement and recognition that there are many ways in which, you know, relationships occur, and many of us are in relationships that are not monogamous, but we limit it to a dyadic relationship, and we define the relationship, we define couples as someone to whom you feel most committed, and the relationship lasting at least 3 months or longer. And in the relationship, at least one partner is an African-American cisgender man living with HIV. So our recruitment approach was a combination of in-person engagement, word of mouth, contacting and meeting and engaging organization stakeholders, key stakeholders, and outreach on social media. We also wanted to mail letters through the UCSF patient portal and find eligible participants via the UCSF health system. And then recruitment was slated to begin in February. And then, of course, as we all know, we had to pivot. We had to adapt our recruitment approach because of the pandemic. So while we proposed all of these, this kind of a hybrid method, what we actually ended up having to do was to take everything online. As some of you may know and are intimately familiar with, everything has to be done, all the research with your participants, either all the in-person engagements have to now be either remote through, you know, things like Zoom, or so, you know, very much reduced. So reduction in in-person visits. And but one of the things that we had to do was when taking this research, this recruitment strategy remote online, we were actually able to expand our reach to a greater geographic area, and we were able to engage with community contacts throughout the entire United States and not just within the Bay Area. We also leveraged our other studies that were focused on, other research studies that were focused on couples, and creatively, and I'm very proud of this point, we were able to actually do some of our recruitment via dating apps. And this is a bit controversial because, you know, I think in terms of the heterosexual world, you know, folks may think, well, you know, if you're in a relationship, what the heck are you doing on a dating app? Well, you know, I would like to challenge that thought a little bit and challenge that as an assumption for a lot of folks who are in heterosexual relationships, and expand our thinking around relationships and put that kind of on its head. So our dating apps strategy was actually by far the most successful in recruiting couples. We also were able to identify couples from other more traditional proposed strategies as well as new strategies. But by far, as you can see, what really panned out during the pandemic was this recruitment strategy via dating apps for couples to recruit Black gay couples. And so as of yesterday, I'm very proud to announce, and this is a huge testament to my team, that we were able to recruit and enroll 24 couples. And I just want to say 24 couples, 48 people, doesn't seem like a lot. But when you think about it, we're not just engaging individuals, like we're not just going to individuals and saying, hey, are you eligible? Yes. Okay. Are you interested in the study? Yes. Great. We count you as N of 1. In order for a person to be included in the study, his partner needs to also agree to participate. So if his partner does not agree to participate, then that person is found ineligible to recruit to be enrolled. So in actuality, it's very difficult to enroll couples into research studies for that reason. You actually need to get two people's agreement to enroll and eligibility and all of that. And we do have a very, eligibility criteria are quite stringent. Anyway, so I'm very proud of this number, and a huge shout out to my team. So just to give you an idea of where our participants are coming from for the R01 study, obviously we have a bunch of folks who are, and N, I should say, N is a sample size term, and N refers to individual people. So N of 10 means there are 10 people, individual people. So there are 10 people from San Francisco. Now, sometimes couples live apart, and that's why we count them as individuals here. We present those numbers as individuals here as opposed to couple as a unit of analysis here. But the point of this visual is to show you where our participants are coming from. So we have quite a spread of, or a representation, whereas before, if the pandemic never happened, we would have never expanded to include people from outside of the Bay Area. So in some ways, the pandemic really helped us to think, beyond the Bay Area and to consider a more diverse sample, and which I think is a huge strength in terms of research for this study. So I talked about for adapting our recruitment strategies and showed you a bit about about the successes of that and the challenges of that. I want to move on to talking about another study in which we've had to adapt a research question, which is obviously changing. When it's actually something that's quite challenging to do when you have a research that's already funded and approved, and then you have to change it midway through, is something that's quite difficult to address. So I want to talk about how we came about that, and hopefully garner maybe some interest from folks in how we did that. So in adapting this research that I'm talking about here is a 2-year study that proposes to develop a way to address loneliness and social isolation among older people living with HIV. Some of us may know that living with HIV really has an impact on aging, and living longer with HIV means for the first time contending. We are having to contend with folks who are getting older, and what we're finding is that aging actually sometimes occur earlier in one's life, around the age of 50. That we're starting to see things like frailty, falls, neurocognitive impairment, things like that, that you would normally observe in older adults, maybe around 60 or 65 or 70. You're really starting to see some of those syndromes earlier. Now, one of the issues, one domain that have researchers' attention these days is loneliness and social isolation in older adults, especially those living with HIV, because lo and behold, stigma is still very much an issue that older folks living with HIV must contend with. There's still a great amount of stigma in being and living with HIV, so much so that some older adults living with HIV may avoid new socialization opportunities out of fear of rejection. And this is based on my own formative research interviewing older folks living with HIV. And what I found is that support groups that are available for, let's say, for example, for older men living with HIV, is that HIV support that are support groups specific to HIV are irrelevant for many of these adults or adults living with HIV because they have it down pat. They have their caring, they're highly adherent to their meds. They're virally suppressed. They're old hats at this game. Excuse the expression, but they've got it down. So for the most part, they don't need support around HIV. They need social connections to regain a sense of control and purpose and living a life, living out their golden years, living with HIV. So again, so the goal of this research is to really try to address psychosocial well-being in older folks living with HIV. And as a social psychologist, I looked to the literature around social isolation, around stigma, around loneliness. And I was really able to find, I found this robust body of literature that focuses on the arts, on belongingness and personal control, and having pride in a group, having pride in achieving something as part of a group, and an arts-based intervention as a very as a promising way to address, to act as a social cure for HIV stigma. And there's a whole conceptual framework that I will present, but essentially saying that having pride in a group increases personal control, belongingness, which serves as a social cure for stigma. And so if the argument is that HIV stigma has a negative impact on psychosocial well-being, then group pride and personal control, belongingness, bonding, and group identity really serve to mitigate that relationship between stigma and psychosocial well-being. So we came up with the intervention. We wanted to propose a project that bring people together to sing. It's called the United Voices Project, and this is a group singing intervention that was found to be efficacious in the general population, and we're adapting for older folks living with HIV. And the proposed mechanisms of action include engaging in regular social activities and establishing a regular schedule. These are mechanisms, these are the active ingredients in an intervention that we think will matter, are the ways in which the intervention will have a positive impact, will mitigate will buffer against the effects of stigma to improve psychosocial well-being. This is how it happens. When you make a dish, when you follow a recipe, these are the active ingredients, okay? Engaging in regular activity, having a regular schedule, developing a sense of belonging and group pride, social bonding, mastering new skills and taking on new challenges, achieving a group goal such as a choir performance. We think that these are the mechanisms of action, okay? So lo and behold, COVID hit, and we needed to find a way to run this study during COVID. Obviously, we can't bring people together to sing for obvious reasons, right? Singing, aerosols generated by singing, not good, right? Not good for safety reasons, and especially for immunocompromised folks, and especially for older folks, right? So there's just absolutely no way we can bring folks together to sing, and the promise of this research, goes up in the air. Now, there are a lot of workarounds. You may have heard about virtual choirs, but can we actually go virtual and still achieve the same effects? Well, we looked to the community and we found a lot of examples. So I'm just going to play a YouTube video of Terrence Kelly and the Oakland Interfaith Family of Choirs virtual concert to give you an idea of what can be done. And so there are a lot of different choirs that have gone virtual, and certainly it is a way of circumventing it's a workaround during the pandemic. Now, we need to be asking the right questions and going with what the evidence suggests in terms of the science, right? We can't just say, well, people are doing virtual choirs, maybe this virtual choir situation can be the solution to address social isolation and loneliness in older adults living with HIV. We really need to go back to the research and ask, can these mechanisms of action be achievable virtually? And my argument and my thinking is that physical distancing is not the same as social distancing. What do I mean by that? It's always been troublesome when we say, let's social distance, when we actually mean let's physically distance, but remain socially connected. It is absolutely doable. It is absolutely achievable to be socially connected while physically distanced. It's the same reason why we can be in a group of people physically, but still feel lonely, right? And by the same token, we can feel connected to people even if we're physically apart. Now, can we engage in regular social activity and establish regular schedule virtually? Yes. We can develop a sense of belonging and pride and belonging to a group online. Yes. We can master new skills over time and we can take on new challenges. Sure. Online. Yes. Can we have a choir performance? Well, we just saw one. So we need to ask the right questions and evaluate whether or not mechanisms of action that was proposed in the proposal can actually be achieved via this virtual platform. And I think the evidence suggests yes. Now, there are definitely barriers, right? Technology access and comfort and knowledge around operating, Zoom and things like that. I mean, of course, there are a whole slew of barriers, but there are also solutions. And in uncharted waters, what better time to try new things and to find new solutions to challenges. It's such an exciting time, and I want to offer this as an encouragement to every one of us who are trying to do the best work that we can under a pandemic, and to really encourage you to continue to explore new ways to address new challenges. With that, I'd like to thank my research team, Hyunjin Cindy Kim, Robert Williams III, Darius Javon Bright. Very special thanks to our community partners, especially Dr. Barbara Garina Achafo, John Hamiga, Nashville Cares, Positive Impact Atlanta, Us Helping Us, and all these other places that we were able to really engage and to help us recruit our participants. So thank you for being here and for doing the work that you do every day.
Thank you so much, Dr. Fessler and Dr. Tan, for those beautiful presentations. Thank you. So now we'll move on to questions. Chip?
Okay. So folks, if you have questions, please put them into the chat box, and we'll go ahead and answer them. We had two questions that came in during Dr. Fessler's presentation, so I think I'm going to direct these first two to him. Do your providers respond to messages sent through the portal, or is the portal used primarily to push info out to patients?
It's bidirectional. So in our portal, patients can send messages to their providers, or we can kind of push messages out. It's a little clunky as a lot of electronic medical records are. It has to kind of go through, it's sort of like everything comes into a common mailbox, and we have to have a staff person who routes it to the right provider. So it's not exactly real time, but it is bidirectional.
Okay. The next question is, have you considered home visits for patients who are struggling with coming in for care?
That's a great question. We actually do have a system for that, where it's called our MORE program, Mobile Outreach, Retention, and Engagement, where we have a van that's kind of existed pre-COVID, where we had a van that kind of goes out and kind of meets patients where they're at, who have difficulty getting in for appointments and things along those lines. So we'll meet them at their home, at a coffee shop, anything like that. That's become more complex, like everything else in the age of COVID, just in terms of, making sure that kind of systems are safe for kind of, going into another person's home and those sorts of things. But we're kind of continually trying to work to kind of get creative and meet up outside with patients and, things like that.
Okay. At the moment, we have no further questions, but Anthony, if you had anything you wanted to bring up, please do.
I have a couple questions. First for you, Dr. Tan. You talked about relationship building with your first study and how our thoughts and interactions and what we do is based off other people. And so I would love for you to talk a little bit more about how your study with couples can help bring revelation to how individuals live healthier in relations than without.
Yeah, so that's an interesting question. Thank you, Anthony. I just want to say on the outset that relationships are a double-edged sword. There are helpful aspects to relationships, and there are unhealthy aspects to relationships. And certainly, this is not a promotion for people to get into relationships. This is obviously not the message. And what the message is instead is to look at in relationships.
Dr. Tan, you're breaking up. Dr. Tan?
Me. Hi, can you all hear me?
I can hear you now.
Okay, I apologize. So what I was saying was that, what are those aspects of relationships that are most helpful, and to also identify and not assume that relationships are always helpful. And so for this study, what we wanted to look at was very much about how partners, even though in relationships that may not be the most, the most romantic of relationships, even in those relationships, there are ways in which partners provide instrumental support. So in relationships where there's a high degree of resilience, where there are capacity to coordinate schedules, to go with each other to appointments, to pick up medication for each other, to even go into a clinic like Dr. Fessler's and to go with each other. And to be another pair of ears during a clinic visit, or to hear about a diagnosis. So these are the aspects of relationships that I'm very interested in exploring, in the hopes of supporting and targeting those aspects in an app to help couples of all ages, not just young couples, by the way, but older folks in relationships to engage in care and treatment.
Thank you for that, Dr. Tan. Another question I have for you is, what are some other ways that you think, other than singing, that you think people can connect with utilizing technology, that you think can combat social isolation for older adults?
Well, I think that's a very good question, and it's a difficult question because of the technology issue and the access issue. And so I think a lot of times, I think, even for myself, who is, I guess I can, by the fact that I can do this presentation via, on this platform, I guess but I don't feel very comfortable using technology, right? And I think that is the primary barrier that that people have, that sometimes is psychological. So I would encourage anyone out there listening that who feel uncomfortable. Obviously not many of the attendees today, because they're able to hear this, but encourage your friends, encourage your parents, encourage your older friends and family to try to push past that initial psychological barrier, and to try, just to be curious, just to be creative, be curious about how to use technology, and you may surprise yourself and actually gain something from being able to listen to connect with someone via Zoom or FaceTime or some other technology platform.
Thank you, Dr. Tan. And Dr. Fessler, we'll wrap up with a question for you. In terms of telemedicine, because I know telemedicine is a new thing, and there are probably organizations, maybe even on this call, who are just starting out with even thinking about utilizing telemedicine. And so can you just highlight some of the positives that have came with utilizing telemedicine, and what were some of the heartaches of making your telemedicine work?
Sure, yeah. So we ended up using a telemedicine. There was a telemedicine functionality or module that was within our existing electronic medical record system. So we weren't using like a standalone platform like Zoom. This is kind of like within our medical record system. There was kind of a module that we could have like video chats and things like that with our video visits. So, I think the positive things are it does allow us to kind of connect with patients in scenarios where they're otherwise difficult to reach. So, I have patients where it's always been a struggle on kind of getting, getting them into clinic, and I might go, I'll see them once every year and a half, and it's sort of, it takes kind of a lot of cajoling to kind of get them in and get labs drawn and talk about health issues and things like that. Whereas if you take away some of those barriers of physically having to come in, to the middle of the DC clinic, where they can literally, sit on their couch and have a visit with me, that takes away some of those barriers. you know, some of the difficulties with it are, a lot of it is just technological. So like we always struggle with the connectivity, and the video doesn't work, like the link's not working. It's not the most intuitive thing to have to, like, patients have to kind of click through like a bunch of different things to kind of get it to come up. So people who are not tech savvy often sort of, you know, say like, yeah, just call me on the phone. And you know, and we can do that. You know, one of the you know, things that made this possible was during the health emergency, you know, Medicare, Medicaid services, you know, allowed for reimbursement for telemedicine visits. So, you know, we can actually, you know, bill for this to insurance and get paid for it and keep our doors open by doing telemedicine, which is largely not the case before this. So I think that's actually, like, everyone had been anticipating this was coming down the line, but this kind of really made it happen much quicker than anyone thought it would. So there's a lot of good aspects to that, but it's certainly, there's inequities built into the system, and I think a lot of times the people who need the most help are the toughest to reach. You know, so I mean, it's not uncommon at all for me to be struggling with kind of a spotty cell phone connection, and someone has a lot of medical issues going on, and it makes it difficult when the kind of technology isn't working properly.
Well, thank you,
Anthony.
Yes.
Anthony, we do. If we have a few more minutes, we have a few more questions that have come up in the chat box. If we have a few more minutes,
Let's ask those questions.
Sure. Are there any concerns about seniors who are on blood thinners getting the COVID vaccination?
Generally not, in the same way that you know, we don't tend to worry about it too much in terms of other vaccines. I mean, the exception to that is sometimes when people, you know, have, you know, hemophilia, you know, or something that's very you know, very profound thinning of the blood. But you know, being on warfarin or another blood thinner generally is fine. You know, people don't need to stop their blood thinner or anything like that before getting the vaccine.
Okay, this one's for Dr. Tan. Based on your experience using dating apps, do you think they will be applicable to other psychosocial studies regarding HIV and aging? You talked about the benefits of using the site. What are the downsides?
We're actually working on a paper as we speak to outline and to explain our the pros and cons of using dating apps to engage couples. So actually, there are a few papers out there, and I would encourage this person to contact me if you'd like, judy.tan@UCSF, and I can send you those references of dating apps. There are downsides. So, for example, when we engage couples into the study, we don't necessarily want to mention that we that the referring partner, for example, heard about the study through a dating site, unless we have, you know, permission from the other person. You know, it's the same consideration of various other types of disclosures that we want to respect. So that's one, you know, potential issue. For the most part, it's been a very successful way of engaging couples, which is a new area. It's definitely been, you know, something that, you know, many studies have used to engage individuals into their research, but not for the purpose of couples. So this is where we will be publishing that paper very soon. So thank you for the question.
Are you seeing an increase of clients falling out of treatment more lately compared to the beginning of the pandemic? And if so, what are you doing to correct this?
Yeah, so we definitely, I think as the initial kind of like transitional shock started wearing off, and we started to realize this was something that was going to be for the long haul, and we needed to, it wasn't going to be something where, you know, you put things on pause for a month and then you kind of resume, you know, the way things were pre-COVID. You know, we started looking more into that and sort of doing kind of dives into our own data in terms of who are our folks with HIV who haven't seen a provider in 6 months and 9 months, a year. So we have the, you know, ability, our particular clinic has kind of like staff that's kind of working on healthcare quality and kind of population health management. So we're able to kind of pull those numbers and pull those lists of patients who had fallen out of care, and kind of proactively we have a small staff of kind of we call HIV care navigators, whose basic job is to kind of foster engagement and care of our folks living with HIV. So they're able to kind of proactively call and try multiple times to try to call and engage patients and get them back in. And a lot of times, the answer when someone picks up the phone is like, it's been 6 months, and the person's reaction is like, oh, I thought you guys were closed, so if there's still like, the messaging and the ability to kind of communicate and push messaging out is kind of a constant challenge. We fortunately have, some support, like some grant supported staff that's there. Even pre-COVID, their job was to kind of foster engagement and care, and we're able to kind of leverage that and utilize that in the COVID era.
Okay. Somebody's asking if the panelists are aware of a program called OATS, Older Adult Technology Services of New York City, now going national. They've created a learning module with GMHC, and they offer online modules and community centers for adults 60 plus can learn tech skills. Let's see if anybody's aware of that. Somebody also threw out there the idea of offering telemed via Xbox and other game systems. Interesting idea.
It's an interesting idea. I have not pursued that.
That's it for the questions. So.
Okay, well, if there are no more questions, I want to say thank you again. Thank you to the audience for joining us today. We appreciate you. I also want to say thank you to Dr. Fessler and Dr. Tan for their presentations. After this webinar ends, a survey will automatically pop up. We do ask that you fill out that survey so that we can bring you better quality webinars in the future. Hopefully you will have a wonderful day, and thank you all again.
Thank you.